so proudly we hailed at the twilight's last gleaming, whose broad stripes and bright stars through the perilous fight o'er the ramparts we watched were so gallantly streaming, and the rockets' red glare, the bombs bursting in air, gave proof through the night that our flag was still there. Oh, say does that star-spangled banner yet wave o'er the land of the free and the home of the brave?
But anyway, our speaker today is an interesting fellow. He started his career with a degree in psychology from the University of Pittsburgh. Then he became interested in physical therapy, so he went to Slippery Rock and got a master's degree there. Well, he still was interested in balance, and he attended the Balance Disorder Institute in Largo, Florida, and has been practicing balance therapy for the last 20 years. I have to tell you, he tuned me up twice. Had I listened to him the first time and did the exercises that he gave me, I wouldn't have had to go the second time. But now I follow his protocol and do my exercises regularly, and I haven't fallen in a long time. Please put your hands together for Steve Kolenda.
Thanks so much, guys, for having me. I kind of thought when I showed up here that I'd probably feel like I was among friends and family, because I've seen many of you over the years, and you've become acquainted with some of the stuff that I do as a balance therapist. Currently, I work with Stracka and McCune over in the Crittmore building. John Stracka, Matt Stracka, Shelley McCune, Deborah Eaton. We also have an audiology department, Sharon Russo and Melanie Schaefer. They're both doctors of audiology. And we have an allergy department. So it's a busy place over there. And I also lead a men's breakfast once a month for our church. And my wife recommends that I always share a personal story that might kind of help drive home the message that I'm trying to get across. That fish there is a steelhead. It represents the last trip that my son and I went on up to Erie. We try to do this every year. Last year there were 5 feet of snow in Erie, so we didn't make it. But he and his wife come from Michigan and visit for a whole week over the Christmas break. He's an engineer for General Motors. She's a teacher for a private Christian school. And on December 27th this year, we went up to Erie and we did our annual steelhead fishing trip. It's become just a great thing for us to do together. This time, as we were driving to Poor Richard's Bait Shop, we were just reminiscing about the 2 times before how great a time we had. We were catching fish, and no one around us was catching fish. We had this secret weapon. It was called the Steely Omelet. It was a little fly, and it was bright red and yellow, a little bit of orange in it. And we thought that was our secret weapon. Well, we got to Poor Richard's Bait Shop, and after we bought a few supplies, I looked down, I said, what color of salmon eggs should we buy this year? And the guy behind the counter said, white. And we both looked at each other and said, we'll take the bright red and orange ones over there. Well, we get to the stream, and of course we're 10 minutes late for some reason, and now people have taken our favorite spot, the best hole around. I step into the water, my waders fill up with ice cold water within the first couple steps, and we fish all morning. Not a bite, not a hit, and people around us are catching fish. We get out to get warmed up, go back in, no fish. We change positions because that's got to be it. There's got to be fish somewhere else. And we get out of the car and we just hike and wade and wade. It's a long day, no fish, no bites. And finally, we're at our last destination. There are about 10 minutes fishing a really nice hole, and some guy walks up to us, throws his lure in a couple times, and pulls out a brown trout like this. I didn't even think a fish could live where he was fishing, and he pulls out this beautiful fish. And I said, what are you using? He said, white salmon eggs. So we're walking back to the car, and we're fishing little holes, and I realized I have white salmon eggs. I think in my or in my fly box, I have one white salmon egg. So at this one hole, we start fishing, and my son says, you fish here. It looks like a better place because we're thinking this is the only thing that's going to work. And then I snag it, and I think, oh, no, I'm going to lose this single white salmon egg, and it breaks free. And I keep fishing, and it's another snag. No, it's a fish. And that was the only fish that we caught that day. I hand my son my fishing rod so he can now use the white salmon egg. And I want him to catch a fish. He snags it in a tree and loses it. That was it for the white salmon egg. So anyways, the point of the story is, sometimes we come across people that have a little bit more knowledge about certain things, and the pride that was in us that morning just didn't allow us to listen to the guy that really knew what we should be fishing that day. The water conditions were completely different that day than the previous 2 times we went. So I'll oftentimes talk with my patients, and the government and Medicare and different organizations have really become involved in meddling with all the things that we do. And now they kind of force us to ask, have you ever considered a walking aid like a cane or a walker, whatever might be appropriate? And most of my patients, the pride swells up in them right away. And I'm too young to use a cane. I'm only 85, and that's kind of the response I get with most people until they start to understand what the process is. And I do actually look at canes. I'm hoping that they're temporary and that they're going to just jumpstart some of those natural processes that are already ingrained in our brain. The circuitry's there. We've just lost it for some reason. So we're talking about balance today. Definition of balance is the ability to maintain the body's center of mass over its base of support. If we're standing in the anatomical position, which we rarely do, this is it, and our center of mass is right around our sacrum, right anterior to our sacrum. But once you start moving different body parts, or there's a lot of different things that can influence where that center of mass lies. Even our posture, if we have a forward head posture, or I hate to say it, but my belly has grown a little bit over the years, and those sorts of things can influence where our center of gravity or our center of mass is. I have to look at 2 different things. First, static balance, when our base of support, our feet, remain stationary and only the body's center of mass moves. So when I'm standing or when I'm sitting, this is static balance. If I'm standing, my ankles can actually do all the work to keep me balanced. I really don't need very much. And the reason we have to look at static balance is because if you don't have good static balance, and some of my patients with inner ear problems are swaying, and the ankles just aren't good enough. Dynamic balance is when both the base of support and the center of mass are moving. And oftentimes the center of mass is outside the base of support when we're walking. So when we advance a foot, now our center of mass has gone forward and we're on one foot, and that becomes a little bit more challenging. And so now just the ankle muscles can't be the only thing that are going to keep us balanced. Our hip muscles, sometimes when we walk reciprocally, so one hand's back while the other hand's forward. Balance used to be thought of as a simple set of reflex reactions. I trip and I don't even think about it. My legs start moving, my arms start moving. Now, balance is seen as a flexible, functional motor skill that can adapt with training and experience. If you don't hear anything else today, that's the most important thing, is balance is a skill, and that we can influence balance by training, by working together, and it's oftentimes a team effort. Whether you have a personal trainer at the gym or you go to a physical therapist, these are, we can influence balance because it's a skill, because it's learned. Balance is reactive, proactive, adaptive, and organized by our brain on prior experience and intention based on pre-programmed yet flexible muscle activation patterns called synergies. So we can plan for balance. When we're walking and we see a frozen puddle, we walk around it. There are just things that we can do to adapt to make sure that we're safer. By the way, on that fishing trip, I did fall in the creek. I slipped, I went up, I landed on my one arm, so now my two legs and my one arm are wet. And I had to deal with that. We all fall. There's kind of no getting around it. What happens when we fall? Do we get hurt? Are we able to protect ourselves? And are we doing all the things possible to avoid falling? There are things within us that help the brain figure out how to keep us balanced. We have sensory input from 3 different sources: the somatosensory system, the visual system, and the vestibular system, which is in the inner ear. From the somatosensory system, we get our support surface reference, our feet, and our ankles, and our knees, and our hips are all sending messages up to the brain. From the visual system, we get objects in the environment reference. So when I look back, I see a doorway, and I know there's perpendicular and there's horizontal, or and all the different seating. Our brain is using all that information to help keep us balanced. And then our vestibular system, it's unique because its reference is the vector of gravity. Gravity is constant. So when our brain has to decide what information to use, that is a good source as long as there's nothing going wrong with one or both of your vestibular system. Then the brain has to figure out what to do with it, and then it sends out a message to your muscles to keep you balanced, to help you walk, to help you function. So all these 3 sources of information work together to create balance. We'll talk about the somatosensory system. As information comes in, the brain has different parts of it that are mapped out to, that are responsible for the different parts of our body, not only in the motor cortex, but also our sensation. And look at all the different things that are coming into the brain from our feet, our ankles, our muscles and tendons and ligaments, the skin, light touch, deep pressure, proprioception, which is basically body awareness, 2-point discrimination, temperature, vibration, sharp and dull. And our brain is able to use all that stuff. And there's actually an overabundance. I was talking to someone here who mentioned his wife had a peripheral neuropathy. The sensation in the feet are missing. But there are other sources of information that the brain can use. And that's the good news, that it's more than one thing. Researchers have concluded that that people rely primarily on proprioception and cutaneous inputs for normal, quiet stance. So I'm up here swaying a little bit. There's a 2-point discrimination nerve in my feet that's telling me how far I'm going and making sure that I'm not going a little too far and losing my balance. Now, age does have an influence on our peripheral nervous system, but that's not the final word. There's a diverse and non-uniform decline in sensory structures and functions across the span of life, and age-related decline of sensory fibers occurs earlier than motor fibers. So some of this somatosensation starts to disappear. There's a lot of it, though, so don't be discouraged. How about our visual system? Safe gait, safe balance, all require good visual acuity. I was talking to someone who just had whose wife just had her cataracts removed, and now vision is perfect. Cataracts will influence our visual acuity. Contrast sensitivity and depth perception, they all are used by the brain to influence balance. And then our vestibular system, which is this organ right here. As you can kind of see, there are 3 semicircular canals there. That is just like an internal gyroscope. I was talking to a pilot here who knew exactly what I was talking about. It measures yaw of the head, roll of the head, and pitch of the head. So one of the things the vestibular system does is it measures linear acceleration. So the brain has to know if the head's accelerating and the direction it's accelerating, because the other thing that the vestibular system measures is angular velocity, which is what I was referring to with the yaw, roll, and pitch. And so our balance is maintained through these vestibulospinal reflex, which comes directly from the vestibular system to the brain, and then the brain sends a message to the balance muscles to keep us balanced. The vestibular system also influences our vision and provides for gaze stabilization, which is clear vision during head movement. So when I turn my head in different directions, my brain receives a message from my vestibular system, and then the brain tells my eyes what to do. It tells my eyes to go exactly opposite of what direction my head's going. Otherwise, the world would be a blur whenever we're walking, moving about in the middle of a fall. We need information when we're in the middle of a fall to help protect ourselves. I see a lot of vestibular patients who are experiencing vertigo. Frankly, Mr. Gustafsson, it's one of the worst cases of vertigo I've ever seen. This is what patients feel like. It's not what I see when I look at them. They're experiencing this sensation that the environment is moving. That's what vertigo is. It can be a catch-up movement, it can be a jump or a bounce, or it can be a spin. Anytime there's an illusion that the environment is moving, that's the sensation of vertigo. So, again, we're talking about that balance is a skill. We can maintain that level of function just by being active normally. Our balance can deteriorate from its current level, usually because of, as you see down below, not using the skill. And much of the deterioration in balance associated with age is because we just start to slow down and stop moving. The good news is we can recapture or improve balance skills that have been lost. And sometimes it's a team effort. Hey, if you want to just start getting more active and you're safe, then do that because it's going to benefit you. If we're going to talk about balance, we have to talk about falls. And the Kellogg International Group defined falls as the unintentional coming to the ground or some other lower level other than as a consequence of sustaining a violent blow loss of consciousness, sudden onset of paralysis like in a stroke or epilepsy. So, when these people land on the ground, is that going to be a fall? No, because they're intentionally chasing some ball. Who knows what kind of ball it is, but their goal is to be in control of the ball. So when they land on the ground, it's not a fall, although they may sustain a concussion from that. So there are different fall factor categories that we as practitioners look at when we're trying to help someone with their balance. And some of the factors for falling involve extrinsic causes, and these are causes that are external, such as the environment. So, grab bars in the bathroom, the use of ladders, the use of a chair as a ladder, or the bed as a ladder, that could be a danger. Clutter in the area, trip hazards, throw rugs, and stairs without railings. There are also some intrinsic factors that will influence our balance as well. These include balance disorders. Some people have vestibular problems or stroke, vertigo, misperceiving the environment, such as with a vision disorder. And if you'll recall, I said that the brain can kind of pick which source of information it's going to put most of its weight on. We've all experienced this. You're sitting in the car, you're driving, your foot's on the brake. The car beside you starts to move. You feel like you're moving backwards. Even though your somatosensory system said that you had the brake on and that you weren't moving, your vestibular system didn't sense any acceleration, linear acceleration, and yet your brain listened to the wrong source of information. So we can actually train the brain and retrain the brain how to pay more attention to those sources of information that are more reliable. So the causes of falls, a summary of 12 studies. The very first one is the external factors that we talked about, environmental accidents, trips, that sort of thing. And then the rest, except for I don't know what other specified is, the rest are intrinsic factors, things that we face from a physical standpoint in terms of illness or mentation even. Location, location, location. Where do people fall? They fall where they spend most of their time. 25% of falls happen in the bedroom, 8% in the kitchen, and 22% in the dining room. 44% end up on the ground, 16 are on stairs, 4 are in bathrooms. 75% of the falls are during routine activities of daily living. Eating, bathing, dressing. How about the trying to balance now that we're getting older? I'm having a hard time putting the pant leg in. Transferring, so you're getting in and out of bed or in and out of a chair. Remember, a fall doesn't have to be to the ground. If you're standing up and you lose your balance and you fall back into the chair, that's considered a fall. Maintaining continence. We go to the restroom. We thought we emptied ourselves, but our prostate tricked us. And so 15 minutes later, we have to go again, but we think, I was just there. I'm doing something important. I'm watching a good TV show. And now it's time you really have to go. And you get up and you're rushing to the bathroom and a fall occurs. So we got to watch those sorts of things. Fracture's the most common injury after a fall. I'm seeing more and more concussions, probably because they're being recognized as concussions nowadays. Women are more likely than men to be hospitalized. But look at this. About 40% of older adults that fall will decrease their functional activity in the next year. So we just start to back off. we don't want to fall again. Other medical conditions, anemia, decreased cognition. I'm dealing with memory issues sometimes. It's like, did I just do that? If you're on more than 4 medications, that kind of puts you at risk for falling, and especially the antihypertensive drugs and the diuretics. They decrease our blood pressure, sometimes too far, or we get rid of too much fluid and we're dehydrated. I just saw a gentleman in his lower 60s the other day. He came in, he's looking pale. He said he almost fell in the parking lot. He hadn't been drinking much. I'm asking him questions. He was drinking a lot of coffee and not much water. I took his blood pressure, and it was below 100. It was probably like 90 over 40. I got 3 cups of water into him, and it increased his blood pressure back up to where it should be, and he was feeling so much better. His color returned. We tend to not drink much anymore as we get older because we don't want to have to go to the bathroom, especially in the middle of the night. So plan things. Drink a lot more during the early day and then back off at night, so at least you're hydrated properly. Does fear cause falls? Well, the fear of falling is associated with gait changes and reduction in activity. So I start to take smaller steps, and maybe I'm shuffling a little bit more so I can get some of that somatosensory information from the bottom of my feet. Fear of falling is not an independent predictor of becoming a faller, but those who are fearful do fall, but those who aren't fearful fall. I've probably fallen once a year for the past 4 years on ice. It's always fishing too. I have to rethink this. Development of fear of falling may be related to other factors that place someone at risk. So you have an orthopedic problem, you're having some pain, so you change your gait pattern. And now you're limping, and you're not quite sure of how safe you are and how stable you are. So now you start to develop a fear of falling. If you do have a fear of falling, it is good to have someone like myself do a comprehensive examination so that we can fix those things that are bringing about that fear. In Pennsylvania, the trauma registry found that 60% of all trauma to people aged 65 or older resulted from a fall. If you're 85 or older, that's 81% of trauma. But the good news is there is evidence that supports doing the right things to the external factors, the environment, installing stairway protection, grab bars in the bathroom, not using chairs and other home devices as ladders. They all work, and we can, we talk about those things when you come to visit me. So why does rehab work? And this goes back to the thing that I said, if you remember one thing, remember this. Balance is a skill. Use is a unifying biological principle. Use is anabolic. That means it builds things up. Disuse is catabolic. It breaks things down. So the less you do, the less active you are, the more it's going to influence some of these important factors that we talked about. Neuroplasticity, that's adaptation. It's a continuum of short-term changes in the efficiency or strength of synaptic connections in the brain, and it becomes long-term structural changes that organize the number of connecting neurons. Old dogs can learn new tricks. It doesn't matter how old you are. This is a lifelong process. And when someone experiences a stroke and one part of their brain has been damaged, another part of their brain can take over. And if we pound that hard enough and ingrain that hard enough, it can become a permanent structural change. Substitution. So say you have a peripheral neuropathy, so your somatosensory system isn't working really well. Well, you still have two others, your vestibular system and your visual system, and the brain's usually pretty happy if it has two systems that it can rely upon. And someone that's visually impaired, we know that if we put a cane in their hand, they're going to get more somatosensory system from, or information from their fingertips, and they're going to know more about their environment, so that balance can be enhanced through adding something like a cane. Neuroprotective factors. There's emerging evidence from animal and human models that exercise, learning, and certain medications are neuroprotective. They just kind of preserve things if you're active and if you're doing the right things. And then education, obviously. Use it or lose it. We've heard it before. 35% or 34 to 50% of hospitalized older adults experience a decline in functional status between admission and discharge. Why is that? Well, hospitalization is forced bed rest, undernourishment because no one likes the food, and hospital-induced illnesses like urinary tract infection, skin infections, that sort of thing. Older adult patients were 3 times less likely to decline in functional status with nursing-initiated interventions, such as mobilizing the patient. You don't have to wait anymore. The doctor's ordering physical therapy. If you're in the hospital, as soon as you're stable, someone's going to come and walk you, or you're going down to the department to get walked, because they now know that this research has shown you got to get moving. You don't want to keep losing functional status and declining in it. So here's an interesting concept, walking speed. And we know about the 4 vital signs. They say, or they used to say possibly 5: blood pressure, pulse, respiration, and temperature. Someone added pain into that, which was a really bad thing to do. One of the American Academies of Pain really pushed hard to get pain considered a vital sign. And then the Joint Commissions jumped on board a little later on and had us asking everybody about their pain. And now we have an opioid epidemic because people weren't thinking. But anyways, walking speed, that's my profession, so I'm all excited about that. It's almost the perfect measure. It's reliable, it's valid, it's sensitive, it's specific, and it correlates with functional ability and balance confidence. Walking speed has the potential to predict future health status and functional decline, including how likely you are to be hospitalized, discharge location, are you going home or are you going to a nursing home temporarily, and mortality. Walking speed reflects both functional and physiological changes. Improvement in walking speed is linked to clinical, meaningful changes in quality of life. And walking speed is easy to calculate, distance over time. So we lay out a little path and we say walk that, and we use a timer and we say you're walking at this rate, meters per second. And here's a chart of the different walking speeds. And it kind of appears that if you're above 1 meter per second, that you're doing pretty well. If you have to cross the street, though, it's going to be more like 1.2 to 1.4 meters per second. And we actually do walking speed as a comfortable speed and then as a fast speed to see if you're going to be a safe community ambulator and able to walk to cross the street. And we have norms. We know what you should be able to walk. And if you're in the lower speeds, 0.6 and below, someone's going to be helping you with your dressing and bathing and other activities of daily living. You're more likely to be hospitalized if your gait speed is slow, your walking speed. Oh. So anyways, walking speed, though, is a good indicator for us. But just because you're walking slowly doesn't mean you should start walking faster. That's a bad idea because you're probably walking slow for a certain reason. And when you come to see me, I'm going to look at flexibility of your lower extremities. I'm going to look at balance, both static and dynamic. And we're going to look at things like blood pressure. When you're lying down and when you're standing up, does your blood pressure drop too quickly? And that's why you're feeling unsteady or dizzy. So it's real important not to just try and address some of these things yourself if you are a faller and you're feeling unsafe. Don't just try and walk faster because that is unsafe. Come to a physical therapist and let us help you improve walking speed, because I won't test someone and then the next time I test them say, go a little faster this time so I can look good and your numbers are better. I see improvements happening just automatically as we address the issues that are causing balance problems. An inner ear problem, a vestibular problem, a musculoskeletal disorder, or just inflexibility. Over time we start losing neck range of motion. Well, that's how the vestibular system is activated, by moving the head. And so if you're doing this now instead of looking quickly, then your vestibular information isn't quite available. And again, we can train the brain to capture that again and to start listening better to that. And that is it for now. Time for questions. Yes. Oh, okay.
Curious, how does this fit in with Medicare?
Oh, it fits in well with Medicare. As a matter of fact, one of their strong suggestions to me is to do a fall risk assessment on the people that come to see me. And they pay for physical therapy, and that's what you're doing. You're coming to a physical therapist or some other practitioner. Medicare pays for physical therapy, and especially for balance therapy. They have a pot of money that they say you can use this for physical therapy and speech therapy. And then once you get to a certain limit, once the patient uses that money up, say in a physical therapy department, then we have to add a different modifier to get more money, because if it's a balance problem, they want that fixed. And so Medicare is willing to pay additional money than the original amount that they give out for everybody.
And what if you're taking like 2 different types of physical therapy?
Well, again, that'll be draining from the pot. So I see a lot of my patients once a week and then give home exercise programs. So we're not really draining the pot as quickly as, say, you had a knee replaced and you're being seen 2 times a week for 8 or 12 visits in a short period of time.
Do you need to be referred?
Kind of yes and no. People do. I am a direct access physical therapist. I'm licensed as a direct access physical therapist, so people can come to me. Not all insurances recognize that, but what I do is I will evaluate you, and then I'll send a report to different doctors that are a part of your life, your primary care doctor, maybe a neurologist, maybe an ear, nose, and throat specialist. And they usually say, yeah, this is a good idea. I think we're going to sign off on that. So that becomes my prescription. But it always is good to even let your primary care doctor know, I think I want to go see a physical therapist for my balance. And they're usually pretty agreeable to that sort of thing.
How does a condition like dementia figure into what you're working on here?
Yeah, dementia does influence our rehab. And sometimes what we have to do is we have to get someone's caregivers to participate in the process so that you can actually follow through with a home exercise program with the help of a caregiver. I have patients regularly who have caregivers bringing them in, and they participate in the rehab process. With dementia and other forms of cognitive problems, safety awareness can become an issue. And that's where it's important for us to talk about some of those extrinsic factors where we can change the environment to make them safer, just by removing things like throw rugs and just different things like that.
Steve,
Yeah.
my wife goes to a personal trainer now. She's not going there for balance, but just as part of a regular exercise routine. But she has mentioned that she has balance issues. So my question is, what should a personal, knowing that they're not necessarily professional physical trainers or physical therapists, but what should a personal trainer be aware of, or I should say keep in mind with regard to helping somebody with a balance issue?
Yeah, well, safety is always the issue. And personal trainers oftentimes have at least a component of their training that involves balance awareness and balance testing and doing some balance type activities. Some personal trainers involve yoga or Tai Chi in the program just to address balance. But again, safety is the key, and it's oftentimes good to go to someone that is trained specifically in balance and vestibular and somatosensory issues, so that we can address them appropriately. And again, and I know personal trainers give home exercise programs as well, but we need to really tailor these exercises to fit where the person is in the balance continuum.
Back in the mid-50s, when I was in high school, my father, who then was in his late 40s, suddenly had onset of, when he was sitting down, he would just topple over.
Okay.
And so he couldn't drive, he was always wary of falling.
Mm-hmm.
And somewhere, I don't recall the details of the history, but along the way, he was referred to a dentist in Philadelphia
Okay.
for some dental work. And that seemed to do the trick.
Okay.
Because after that, he ceased to have these problems. Eventually, he was able to go back to driving and, lived a relatively long life without.
Now, when did he pass out?
He would be sitting. Like I remember sitting in the living room on the sofa, and he would suddenly topple over.
Huh. That's
Or he would be
interesting.
at work, and he would suddenly topple over, fall off his chair.
Yeah. Yeah,
And-
that's known as a drop attack. Would he lose consciousness as well?
I don't recall that.
Okay, yeah, because a drop attack, you don't lose consciousness. Syncope, you do lose consciousness. And so in the list of balance issues was drop attacks. And oftentimes that's related to cardiovascular issues. Yeah, I'm surprised that a dentist helped him.
Yeah, I don't.
But it almost. Sometimes we
medical
have.
journal articles or somewhere where some doctor
Yeah.
heard about it and referred him to this dentist. The other thing, I think he was also put on a medication, as I recall, that contained nicotine.
To do what?
A medication that contained nicotine.
Nicotine. Okay.
But that could be my memory too. But
Yeah.
that's what comes to mind in
Yeah.
thinking about this.
Because sometimes people have atrial fibrillation, the heart's fluttering too quickly, and brain isn't being efficiently moved, or I'm sorry, blood isn't being efficiently moved to the brain,
Yeah.
and then the person goes out of atrial fib into normal rhythm. But that sort of thing can happen, and why the dentist was able to do it, I'm not sure. What's that? Yes, it can. And that's one of the reasons why doctors really want to address it, either with medication or some sort of surgical intervention to make sure that you're not going to get lightheaded and fall because your heart isn't pumping efficiently and it's out of rhythm.
Can your treatment help those with neuropathy? My problem, each time I've fallen is because I'm not lifting my feet up as much, and I'm always, 3 times I've fallen, it's been walking up the front steps, and the top where the concrete is a different height, and I trip and fall down at that point. And
I would say it's always a good thing to get looked at for something like that, because we talked about not only does the brain use your somatosensory information, which you're lacking some of that because of the neuropathy, but you do have 2 other systems, your visual system and your vestibular system. And so we can kind of help the brain put more weight in that information, more reliance upon vestibular and visual information because the somatosensory information isn't available. Also, because of neuropathy, you start to develop gait patterns and habits that will then shorten the length of your calf muscles. And sometimes doing a simple calf stretch can give you that range of motion back so that you're clearing your feet when you're walking.
I've noticed that when I'm walking, I can, my gait, or I can hear myself walk because my foot
You're slapping, your foot slapping down.
Slapping down, as opposed to when I concentrate, I can hit my heel first and stop that slapping.
Yeah, and that's some of the things that we work on in physical therapy. Almost every single patient that walks into my office, I measure flexibility of the calf muscles, because people trip over their toes. Even with good flexibility, we trip over our toes occasionally, but when you have a neuropathy or any type of orthopedic or musculoskeletal issue where those muscles start to tighten, then you're not able to raise the toe high enough to clear the floor. Women that wore high heels all their lives had that position and that muscle was tightened down, so now you have to reverse that. And some women aren't even comfortable not wearing a little heel because there's that feeling of stretch there. Well, it's a good idea to stretch that muscle out to regain functional flexibility of we call it the gastrocnemius and soleus complex. It's a muscle group right in the posterior calf that allows us to have the flexibility so that those front muscles can raise the foot up. So yeah, we typically can help. We may not help the neuropathy, but we can help you walk more functionally and safely.
With the walking in relationship to a lot of us wear sneakers, do you talk about different type of shoes and orthotics that go inside the shoes?
Yes. In my earlier days, I actually used to make custom orthotics for individuals who had different foot problems. And I will suggest, if I see a problem with the feet, I will suggest going to an orthotic maker or even a place like Good Feet. Some of these places can be pretty expensive, and if it's done properly, your insurances may cover custom orthotics for the feet. But yeah, and shoe wear is very important. And we know that if you are diabetic and you develop a diabetic neuropathy, that you're going to have less feeling in the feet. So the shoes have to be adapted for that to make sure that you don't start to cause wear and injuries to the feet that you won't even know about people will sometimes step on sharp objects and not even realize they've cut themselves or that the object is still embedded in their foot, because that's a type of neuropathy from diabetes. So we do look at footwear. I do make suggestions sometimes for individuals who are having a hard time finding a good fitting shoe and a good functional shoe.
When I ride a merry-go-round, I get real dizzy and sick.
Mm-hmm.
I can do anything else and I don't. Is that due to the inner ear, or what causes that problem?
Yeah, that's motion sickness, and that's caused by the inner ear. But the unique thing about motion sickness is you can have an inner ear problem and no motion sickness at all. I see people all the time that have dizziness, vertigo, imbalance, and they're not motion sick. You can have motion sickness and no vestibular problem. So you get on a boat or you get on a merry-go-round and you're nauseated. I have motion sickness in a boat or in some environments, like in the movie theater where things are 3D, and I can get really nauseated. But I don't have a vestibular or a balance problem. And then there are those people that have both. They have a vestibular problem and a motion sickness problem, and they're kind of tied together so strongly that we have to be very careful as we're doing rehab so as not to stir up the motion sickness while we're trying to improve balance. Well, apparently astronauts go through rigorous training to overcome motion sickness, but motion sickness is a hard thing to overcome, and some of my patients will benefit from the vestibular rehab. Some will not, but again, I just have to be careful to do activities that I know aren't going to stir up the motion sickness so that we can actually get to the goal in a more pleasant way. I kind of joke to my patients that I have a gift. I can make people nauseated. And I really do try as hard as possible to avoid nausea and vomiting, but sometimes you just can't. At least initially, before you even knew it was there. So, yes.
15 months ago, in one day, 3 days before Christmas, I started to get dizzy. Now, not dizzy, not vertigo, not Meniere's disease.
Mm-hmm.
I have a problem where I stand up and it feels like all the blood's draining out of me.
Mm-hmm.
I've been to 9 doctors.
Okay.
Nobody knows what's going on. I went and had an MRI done last Friday. Saturday morning, I had my arms full of wood. I ended up on a concrete. Sunday morning, arm full of wood, putting it in the stove. I was lucky the couch was there. And I don't fall.
Mm-hmm.
Yesterday, I spent 3 hours 20 feet up in a tree. And I have no problem up in a tree.
Okay.
As soon as I stand up, I have a problem. When I'm sitting down, I have no problem.
Yeah.
I do have atrial flutter. I have low blood counts. I have a lot of things going on.
You drinking enough water?
I drink Gatorade.
Okay.
There we go.
Well, if you would walk into my clinic and I heard that, I would lay you down, take your blood pressure, stand you up, take your blood pressure.
Done it.
Yeah, and
I do it every day.
Is it good, or does it drop?
123 over 62.
When you stand up, it doesn't drop?
There are times it does,
Okay.
but sometimes, usually it doesn't.
And are you on blood pressure medications or diuretics?
No, not on blood pressure. I'm on Lipitor.
Okay.
I'm on Eliquis.
Okay.
I'm on Proscar.
Okay.
They said 4, I'm on 8.
Oh, yeah. Yeah, I mean, you're the doctor's challenge. Now, because you have the atrial fib.
Flutter.
Okay, atrial flutter. Yeah, and you've been to your cardiologist about this?
I've seen 2 cardiologists. I've had a tilt table test. I've seen a neurologist. I just saw the neurologist. I saw a doctor who took care of, checked my adrenal glands for cortisol tests. I've had pill table tests.
Did you turn when you turn your head quickly, do you get that feeling?
I have a bad neck. I really do.
That's what I just talked about.
I think I want to sort of cut this down, and I'm sure you'll answer other questions if people come up to you afterwards. But how about a round of applause for Steve?
Thank you.